Hello, everyone. Well, welcome to this IACAPAP Special Interest Group webinar. It's a webinar that is on coercive control. I'm Dr. Yewande Oshodi. I'm the Secretary General of IACAPAP, that is the International Association of Child and Adolescent Psychiatrists and Allied Professions. Today, we're going to have a very interesting presentation from an expert in the field, speaking on the very, very topical issue of coercive control and the effect it has on children and the risks of trauma associated with it and abuse in children and adolescents. Without much ado, I'm going to go ahead and introduce our speaker. This, for the records, is the first special interest group webinar organized by the IACAPAP. We are currently in the process of starting several special interest groups, and we are really happy that this is happening. And we're hoping that at the end of this webinar, some of you will be interested in joining these special interest groups and participate going forward. Our speaker today is Dr. Marie-José Van Hoof, who is the CEO and medical director at I Mind You Mental Health Institute. She's a child and adolescent psychiatrist and an adult psychiatrist, a psychotrauma therapist, and an orthopedagogue. I would, on behalf of IACAPAP, welcome our speaker, Dr. Marie-José Van Hoof. You have the floor.
Thank you so much, Dr. Yewande Oshodi, for your introduction and also for the opportunity IACAPAP board is giving to me to present this topic that involves everyone in this world. I'm very glad that I can share a presentation on the topic of child abuse and neglect and femicide involving coercive control. And coercive control as being part of domestic abuse. So I have no disclosures except for that I'm a member or a chair of several groups and committees on the topic. And what I would like to start with, and I stop sharing now, is a documentary after we first have maybe made an inventarization how we're all participating in this webinar by asking you a few questions anonymously, a poll, so that we have a sense of what experience you have with the topic and a little bit about your own background. So you can try to answer them. And here we have the results, which are very interesting. So we have 36% of us being a child psychiatrist, 15% a psychiatrist, 13% a psychologist, 5% a nurse, 5% a pediatrician, and others, 26%. And also some being in training, 37%, and most not being in training anymore. 80% males and 18% male and 80% female and others 2%. And the ages are interestingly kind of somewhere in the middle, between 20 and 60 years mostly. I'm very happy to see there's 10% of First Nations participating. 2% Black, Asian 29%, Hispanic 10%, Caucasian 41%, and with mixed background 7%. And yeah, some of you answered the questions, most of you, about country of birth and country of residence. So we'll close this now and have the other poll questions also asked about whether you have experience with the topic of this webinar, either professionally or personally. Sue will present this. And to the next question. So you can continue, show the results, and continue to the next question. Thank you. 74% heard about the topic coercive control and others didn't. So have you had professional experience with these topics, child abuse and neglect, domestic violence in general, or coercive control in particular? And you can tick all the boxes if you have, or just a few of them, or one of them. And the results can then be presented. Most of us, unfortunately, had to do with child abuse and neglect and domestic violence. And 2/4 almost with coercive control. Thank you. And then our last question for now, whether we had personal experience with these topics. And you can tick all the boxes again, or just one or two. And when the results are there, these can be shown. And also, we ourselves, part of society, have experienced all of these topics, unfortunately. So that's good to know, because sometimes we may pretend that we do not have personal experience, since there's such a big stigma connected to all these topics. But usually it's not the case. I can tell you from talking about the topic. So I'm glad that now we all know how we are sitting here from sometimes multiple perspectives, multiple perspectives also in the world on this topic. So now I would like you to briefly watch a documentary, a trailer, Fred et Marie, that Sue will show us. And click start on it, and then I'll tell you to stop at a certain moment. And if we can hear the sound, that would be helpful. Yes, so even when you can't hear the noise now, I want you to look and see what you see, so that we can briefly reflect on it later on. You can watch the link yourselves after the webinar when it's shown, when it's shared afterwards. maybe we can stop this now since there's no sound, and you can watch it further on later on, because also the sound will make impact. And it's an introduction to coercive control. And later on in the Q&A, I would really like to hear from you what you noticed and what seemed to be maybe a little bit different, something you hadn't expected. For now, I would like to continue with sharing the presentation. There are a few slides I will go through that you can watch later on, because they all contain very valuable documentaries about coercive control. And all of these, some are in other languages, but they can have subtitling, and have been really mindful examples of what coercive control can look like. For example, the case in France of Gisèle Pellicot, who was so brave to bring her case into the open and point the shame towards the perpetrators instead of the victim, was, a change maker, was historical. And this, for example, is a very classical documentary about coercive control, very subtly in a rich environment. This one, for example, has been a theater presentation on the topic, and the Nitinath Chronicles are known for its own reason in underserved communities. The last one, Downpour Resurfacing, that I'm mentioning here, has been made by my friend Francis Nicara. It's only half an hour watching. It's been where a psychiatrist who unfortunately died about 6 years ago tells his life story and how he went through it, having experienced several adverse childhood events and later on trying to recover from it, also through body work. It's an artistic representation and it's very moving. I can recommend it. So what actually do we now mean with coercive control? It's about very serious, one-sided, continuous pattern of behavior and a process that aims to achieve dominance in time and social space. And it's done by taking away the person's freedom, sense of self through demands, threats, monitoring, thereby violating personal and freedom rights of the victim. So it's about power and control, and it can be very subtle. So at least in the Netherlands, where I'm from, research only started recently. In the meantime, in our country, 1 in 8 women are being murdered as a result of coercive control ending in femicide. In other countries, they have other numbers. 50 to 70% is estimated to be coercive control in case of domestic violence. Usually, at least in the Netherlands, people think that when there is a case of domestic controls, there are 2 people who quarrel, and they're both somehow guilty to the quarrel. They have their part in it, and that's why you never can tell, what what is really going on. You can't seek for truth. Well, actually, the truth is that there is a high percent of one-sided violence called coercive control. So I think it's important to identify when that is the case. 30% of partner abuse is high conflict, where people quarrel. And there are also different aspects, different security aspects, and different treatment routes and options, whether you have to do with coercive control or high conflict or any other pattern of domestic abuse. This is in Dutch, but since it was my meaning to just highlight the home where things happen, because when you have people in treatment, especially children, and they grow up and later on they're able to reflect on what they experienced, they draw a house and they can point to what happened in which room of the house and draw what happened. And it's very meaningful if from there you can understand which microaggressions and major aggressions happen to them. So it's about making you very small, isolating you from family and friends, gaslighting, criticizing and accusing, threatening, manipulating you, trying to get a grip on how you live your life, which interest you are able to exercise or not, controlling your finances, controlling your devices, looking into your private devices, and also into stalking, into keeping an eye on you wherever you are. And so also this one, there are threats. This is the Biderman's chart of coercion and coercive control. It's set up originally for torture, but the same principles that apply to torture apply to coercive control taking place in the homes of all of us all over the world. And so that's even more scary when you think of it, because in case of torture, you think, oh, that's only a few people in dictatorial states who, have such a bad fortune that they were born into that spot of the world and came under the grip of a certain regime. But there are many more homes all over the world where a similar pattern of power and control violence takes place every day, every minute, and also creates a lot of victims and even death. So when you're a kid and you grow up in a web of coercive control, what is it what you experience? So then there is an adult in the house frightening the child, hurting the child, denying and blaming the child, and abusing children. And this web is so intricate, like that of a spider, that when you're in it, you can't oversee what is going on with you. You even think it's normal. That's what I hear back from my psychotherapy patients who were in it as a child, but also when they were adult, that they couldn't really understand how they came in and how to get out. And it seemed to be quite normal. So when you look into that, the same principles apply in torture and in coercive control. Installation, monopolization of perception, humiliation and derogation, and induced weakness and exhaustion. So you're the one who is wrong, you're weak, you have a mental illness, you really can't understand what to do and what is going on. Only the perpetrator can. So it creates fear, despair, occasional threats, and the perpetrator exercises omnipotence and omniscience. So he knows everything and is able to do everything. And as a victim, you start believing that is completely true. And it's also done by enforcing trivial demands. So I want you, before you step out of the house, to first go to the kitchen, say, also feed the dog, close the door, and put the keys in a certain spot, for example, as an example of a trivial demand, which could also be done in multiple other ways. So there are also a lot of myth regarding coercive control. At least to me, like 10 years ago, I had never heard about coercive control. So I also didn't recognize it when it was there. And I'm sure it was there, but I just didn't see it. It also, I'll move this. There's one myth that says that incidents of physical violence are most important in interpersonal violence in the family environment. And I grew up that sticks and stones can't hurt your bones, but words can never hurt you. And I now know it's not true. And I know that also because a lot of patients told me how much they were inflicted by all the emotional and psychological abuse that they experienced, even when there was also very serious physical and sexual abuse. The main thing that had corrupted their compass in life was the emotional and psychological abuse. What I already mentioned was another myth where two fight, two are to blame, which is not true, as we know by statistics. And if you experience coercive control, there must be something wrong with you. So this is what often happens in courts all over the world, I'm afraid, that the victim gets victimized twice by the judicial system. Because this is the thought. If you experience coercive control, there must be something wrong with you. Then there's another myth. If the violence was that serious, the victim would have left long ago or should have done so to protect the children. And also that is just not true, because when you're caught in the web of the coercive controller, it's very difficult to get out, and you learn how to anticipate what the perpetrator could possibly do, even unexpectedly. And sometimes, usually, it's best to keep under the radar and stay in, because when you try to get out, you can have even more serious consequences. So another myth says that coercive control occurs equally among men and women, and femicide is therefore a gender-based fabrication. So in the manosphere, this is what they say, right? No, it's just they put the blame on us men, and it's not us. It happens everywhere, and it can be either men or women. But the truth is, the statistics can show that it's usually women being the victim and fewer men being the victim. So we also there is a gender bias. Then there's a myth saying the intimate terror stops after the relationship ends or after divorce. But we know there is a lot of post-separation abuse that uses the children as a shield to try to still power and control the victim. And this makes life miserable both for the adult victim as the children victims. Then there is a myth saying family-oriented protection will solve the problem. Well, no, not immediately, because when you do not take into account that there is a perpetrator exercises one-sided violence, then you're going to propose all kinds of measures that give way a lot of space and power to the perpetrator. And so the abuse continues. Finally, the ninth myth saying that perpetrators of coercive control can be good parents and can improve has also been shown to be just not true. Because when you exercise so much power and control over someone else, crossing someone else's borders, whether it's the other parent or the children, you're not respecting these people, and you pose yourself upon their lives and upon their decisions. So the other parent can't be exercising his or her own way of dealing with the kids because you're imposing yourself on the other parent, and the kids have no room or space to do anything else but what you impose on them. And the 10th myth, femicide is a crime passionnel, or a crime of passion, as the papers usually say, or it's a family crisis. Yeah, that's just also not true. It's not about something went out of hand all of a sudden, we couldn't foresee it. No, it's a structural problem. It has been set up after a long time of trying to get to that point of ultimate power and control. And if that is not a goal that can be achieved, the perpetrator will even try to kill or kill. So here we are. All these things tap into coercive control: insulation, stalking, cruelty, threats, intimidation, physical violence, strangulation. Now, strangulation being a very important red flag, denying access, managing access, and this taps into a homicide timeline that Monckton Smith set up after she did a lot of research on cold cases and found out there are several stages to a coercive control situation. First, you have the pre-relationship history of stalking or abuse by the perpetrator. So most likely the victim is not the first victim. There have been victims before in former relationships. In some countries, it's possible to look into whether a perpetrator had a history of other abusing relationships. Then there's phase 2. The romance quickly develops into a serious relationship, even more fast than you can imagine. So there's a love bombing phase where you feel that how interestingly loving this person is. You've never experienced this, gives gifts, dedicates all his or her time to you. You're completely overwhelmed. You think, wow, I really am very lucky that I meet this person. But however, after that phase has been achieved, the relationship becomes dominating and coercive controlling. And then there is a trigger that, when there's a trigger that threatens the abuser's control, for example, the relationship ends, or there is a pregnancy coming on, there are kids arriving in the relationship, or there are financial difficulties, the power and control escalates. And here you see that, yeah, the next escalation is an increase in intensity or frequency of the partner's control tactics, such as stalking, strangulation, or threatening suicide. So, as I said, strangulation is very important. If that happens in the relationship, in a sexual relationship, it's a sign that there is real threat. Also, stalking is not something that you should just take and experience. It's a serious red flag. Another one, threatening with suicide by the perpetrator, means threatening with homicide. It's not just a threat with suicide. When there is phase 6, the perpetrator may change his mind and choose to move on, and give you even loving interactions, so that you start hesitating whether did you see it right? Maybe it's not that bad after all. But no, it can change very quickly. It can also go forward towards revenge or murder. And from phase 6 to phase 8, when there is actual murder, you can only tell afterwards whether phase 6 was so risky and so dangerous that you should have made other decisions or taken other safety measures. And so families who are in a phase 6 should be taken much more care of. In phase 7, it's said that the perpetrator can plan for the murder, and the murder may involve the adult victim, other parent, for example, or someone else involved, the children, and murder of the perpetrator him or herself. Strangulation, please keep in mind, always a red flag. So when you look for general signs of partner violence, and you're a doctor, you can see these, for example, in high medical consumption, or trying to get help outside office hours. Specific complaints like fatigue, headache, neck pain, back pain, muscle pain, stomach pain, nausea. Of course, these are very vague because you can also have other somatic causes of all these complaints. When people really seem to be looking for somatic causes of the complaints, that might also be triggered to ask for any trauma, any adverse events. When people change providers very often, or ask for many referrals, or move to other parts of the country, that's sometimes also a cause for concern. When you really do not get a good answer to general questions, defensive answers, about tensions when there's no open communication, avoidance of making eye contact, quickly moving on to another topic, that's can be a sign of partner violence. And when people ask repeatedly for prescription of tranquilizers, when they have a moderate to poor response to prescribed drugs or physiotherapy, when they frequently consult with the children, when there are minimal symptoms or illness, or when there is a divorce, or when people are in the process of ending the relationship, then this may raise in combination concern to look into the partner relationship and the situation in the family, what is actually going on. And the only thing that helps is when you ask for it. When you ask about the relationship, when you ask about violence, when you ask about trauma, loss, separation, any relationships problems. If you do not ask, you won't get any answers. So specific signs can accompany the general signs, but when you have specific signs, you still have to look into violence, trauma, family situation, partner relationship. If you do not ask, you won't get any answer. So if you have like hyperventilation, anxiety, poor sleep, lethargy, concentration problems, eating disorders, depression, that might be a sign there's more underlyingly going on. Any suicide attempt, strangulation during sex or outside, sexual abuse, assault is of concern. If there are problems with the female genitalia, when there is, for example, vaginal fluoride, sexually transmitted disease, sexual dysfunction, miscarriage, blood loss, when there is trauma or injuries that do not have a good explanation, or when people do not seek help for it and come much later on, that's a sign of concern. When there is alcohol or drug abuse, that is a sign of concern. And yeah, especially in combination with known violence or violent crimes. Yeah, so I think it's always, that's a recommendation of general practitioners that I refer to here. It's always good if you get a full picture of violence, trauma, loss, of reproduction history when it's a woman, and any psychological problems. When there is suspicion from history or the context that the request for help and the clinical presentation might have to do with violence, please look into it. Do not leave it to someone else or for a referral or for some other time, because when victims present, they need help, even when they say this little. Because especially women, when they experience violence, they give subtle hints during the consultation. They wait, they hope that the doctor will ask further questions. If you don't, the window of disclosure has gone, because they don't dare to. They're much too afraid to do so. So yeah, so also about the relationship, sexual experiences, ask about it, because people are not going to come up with that themselves. Any other things, questions like, has usually a woman, but can also be a man, been afraid of her partner? Is an important question. Mostly this is not asked, but it's when there is coercive control, this might very well be the case. And then it's important to listen with compassion without judging. Leave that at home. And to confirm that intimate partner violence is never permitted, and to emphasize and safeguard the confidentiality of the consultation at all times, and to take action. Do not just listen and do nothing. So remember that a patient, after a long period of silence about the situation, finally reveals the violence in the consultation room, is often afraid of reprisals that wait her when her step becomes known to the perpetrator. So, in case of women, often spend years deciding whether they should stay with their partner or leave. So when they disclose, make a plan how to go about stepping out of this relationship and protect the victim, adult victim, and the children. So you have to assess danger criteria together with the patient, for example, with regard to the children, and provide information about aid organizations, phone emergency chat service, women's shelters, if these are available in your community, in your country, in the region where you are. If you want to read further, this can be used. It's a combination of Dutch and English literature, but also the other links provided on the documentaries may lead you towards other sources of information. And one of the purposes of setting up a special interest group on coercive control is that we will gather more literature from all corners of the world and try to inform ourselves about the situation in our own region, in our own country, and how we can empower the victims of child abuse, domestic violence, coercive control, and empower ourselves as professionals in order to better help the victims. So this, again, I had wanted to show you, but with sound, so you better can watch it afterwards when you have more time. And with this, I would like to close my introduction on the topic. And thank you for your attention. And so then I think now there will be time for questions and answers. So I'll give the word to Sue.
All right, thank you so much. This is Dr. Yuande taking over, just to anchor the Q&A with you. Thank you so much for this very, very enlightening webinar. Dr. Marie-José van Hoof,
Very well.
I've been practicing and I'm getting it, has spent the last 45 minutes speaking to us about coercive control. She was able to establish to us the different experiences around coercive control that is in the room. Some of us have seen it professionally. Some of us have lived it, experientially. She shared with us some of the data around coercive control and spoke about the control web. I'm just highlighting the few important punchlines in the course of your talk. She also spoke through extensively different myths around coercive control and the faces around homicide when it happens in relation to coercive control. Dr. Marie was also able to highlight to us the signs of partner violence and gave us a very comprehensive recommendation list. So now the floor is going to be open to take questions. We do have a few in the question and answer box, and I'll take them in batches so that we can move through them very quickly and just support her as we go through the Q&A sessions. So the first question in the question and answer box, and I must say before we jump into the Q&As that we have 107 participants. Currently, it's up to 104. I think some people just dropped off because participants may not be able to see the other, just so you know that other people are on the webinar and listening attentively. So the first question says, why does all domestic violence not come under coercive control? And secondly, how many percentage of women, children, and men are thought to be victims of coercive control? Maybe I'd let you quickly speak to those two before we go on and do the others.
Yeah. So at least in the Netherlands, where we have those statistics from a few years ago, 2/3 of domestic violence seems to be coercive control. 30%, about 30%, not the case, more high conflict. So domestic violence covers more than just coercive control. It's a very specific form of violence.
Okay, so coercive control is a type of domestic violence, is that correct?
Yes, so coercive control is more about emotionally, psychologically trying to control and exercise power over someone and adults and children. And it can go along with physical and sexual abuse, but it doesn't necessarily have to be so. So for example, in the Netherlands, the emotional psychological part, you can't be condemned for, right? So it's by law, it's not under criminal law yet.
Mm-hmm.
In other countries, it is.
Okay, thank you very much. So let me quickly go to the other two questions. Are neurodivergent individuals victim or perpetrators of coercive control? For example, an ASD person, due to their rigidities, might exert coercive control and can be victimized also as they do not understand subtleties or might be passive. So ASD individuals, where do they fit in? Are they victims or perpetrators? And the second one I'll add to that says, a lot of the characteristics of coercive control overlap with abuse done by individuals with personality disorders. How do we differentiate these? Over to you, Marie.
Yeah, so in my opinion, it doesn't matter who exercises violence and whether that person has a personality disorder or doesn't understand, can't mentalize it well because of an autism spectrum disorder or any other cognitive deficit, right? I don't care who perpetrates the violence. The violence itself is wrong and should be stopped. And in case of coercive control, it's a well thought of pattern. It's really something on purpose, consciously applied. It's not something that just happened because you do have an autism spectrum disorder, right? You go after it.
Okay. So in essence, you are saying that it's not about the neurodevelopmental deficit, it's about the behavior that is wrong, and we should address that. That's
Yes,
what you're
yes.
highlighting we need to focus on.
And not on the stigma being the victim of someone who perpetrated the coercive control or any other kind of abuse.
Okay. I would like to ask one question before I read the last question here. When we saw the write-up for this webinar around coercive control and the linkage towards child abuse and child trauma, can you paint a picture for us to just help us understand? Because as IACAPAP, we are child and adolescent mental health professionals. Help us understand that association of coercive control that's happening maybe in a marriage and a relationship, and how that dynamic affects the mental well-being of the children in that setting.
So when one of the parents is being coercively controlled, that means that that parent can't be as good as a parent and protect the children from all other abuses, whether physical, emotional, psychological, or sexual, that usually also happen when there is coercive control of the partner. And when there is a lot of emotional manipulation, psychological threats, etc., the children, if they are not the targets of the control, at least are the witnesses of the violence towards the other partner, the other parent. Also, being a witness is a form of child abuse. And usually it also goes along with the neglect of emotional needs, of physical needs of children. And so even when the children wouldn't be the direct target, they do experience the consequences of the coercive control to the other parent, and aspects that they witness that are no good for them.
Yeah, so children suffer by witnessing and also by, observing what's going on or experiencing it. I think that's what you're telling us.
They are presented with an abnormal normality.
Exactly. Okay, so two next questions. With an increasing awareness of neurodiversity, it's very similar to the other one. Is there any information about neurodiversity and coercive control? I've noticed some tendencies whereby the rigid thinking of ASD can lend itself both to controlling behavior, more so in men, notwithstanding many of those with ASD are not abusers. We know that, and increased vulnerability in some women. The second question I'm going to add to that, and so we can be quick. Coercive control is considered, it's actually a comment, to be a foundational underpinning aspect of domestic violence by many, rather than a separate form of domestic violence. You may want to comment to that. I'll just add this question. How about overrepresentation in religious organizations? This is often supported by the religious community, which causes gaslighting and further alienation. So could you speak to these two questions and
So
comments?
as to neurodiversity, we do not have enough research on the topic. So it would be very good in the special interest group to look into the question of neurodiversity, personality disorders, and etc., in order to get a more complete profile of perpetrators. However, it could also be that perpetrators have a traumatic background, having experienced a lot of adversity themselves, or whether it's neglect or maltreatment. So we don't know that because there's not enough research into that area. And then the other question, the last question,
had to do with overrepresentation in religious organizations, causing
that's
gaslighting and alienation.
we know there are particular communities that tend to coercively control their community members. And these communities have raised coercive control onto the meso level. So the micro level is in the homes of families. Meso level is community organizations, etc., where this way of behaving becomes the norm. And the geopolitical level, we also know there's also coercive control going on the geopolitical level. So when you recognize it in the family and it has been raised as a community thing, you know that, this is really something to be tackled, and staying into this community will, it will be very difficult to not be involved. To get out is also difficult. We know that from sects. But the religious aspect is a well-known aspect. And one of the documentaries on Ruinerwold, it happened in the Netherlands, also refers to a religious aspect. So if you're interested in that, have a look.
Okay, so the last question, and then we'll just speak a bit about the SIG itself, says, can perpetrators show any improvements with interventions? Do any interventions work?
We need research on this. So far, we know it's a difficult problem to solve, because usually perpetrators do not want to get help. If they do get help, they want it for their own purposes. As long as it serves them, they pretend they want help, but they do not really improve because they're not really working on themselves. Very difficult to reflect on themselves. They manipulate the truth all the time. So they come up with different lives that they have lived, or different diagnoses that they got from different people, whether it serves them or not, or whatever. So it's difficult. It's really difficult.
So we're not aware of any interventions that really work, is that it? Or they don't engage?
I don't know of interventions at this very moment. And, you know, if there would be interventions that would be really helpful, I think that would really serve the community. But most important now is, I think, to just stop violence, any violence. Do not tolerate violence.
Yeah, and I think one of the reasons is for this SIG is to create more awareness about this situation and how we can support. Correct.
Yes,
So yes.
because
So
children
yes, please
are
go
in
on.
a situation that they can't escape. So adults, whether in the family, outside the family, professionals should be the ones to stop, to signal when there is violence, and to stop the violence, to help stop the violence, and make sure that safety is assured for the children so that they can develop. Because when children are in a situation of violence and traumatization, they stop developing. They get behind cognitively, emotionally, psychologically, in any respect. So, and also they can develop psychopathology much later on, right? So only disclose, for example, what happened to them when they are an adult, when it's safe enough to disclose.
Yeah. Okay, so I think we're coming to the very end because, in the interest of time, we're going to just round up in another 5 minutes. I wanted to just read some of the commendations. It says, someone says, thanks, very informative. Another person says, thank you for your speech, Dr. Bringold, Switzerland. You had greetings from Dr. Behar Canberry from Pristina, Kosovo. How can people get these slides? Would they be available for sharing? Because we've had a few requests about the slides. Would it be something you'd be happy for us to share? Is that okay?
Yes, you may all use the slides, get back to me with questions, join the special interest group if you're applicable for it, create more initiatives in your own communities and regions and countries, and share them with the SIG of the IACAPAP, so that we become more versed all together over time and inform each other about the developments.
Okay. So on a final note, we just want to remind everyone that you can join the special interest groups by going onto the IACAPAP website. The details for the SIG on coercive control is there. You're welcome to join. It's open to all attendees that are interested. This special interest group would include webinars, research, conference presentation. Am I correct, Dr. Marie? Yes, exactly. And you can get a copy of the slides. If you look at the chat box, details are there. I just want to remind you all that this webinar is hosted by IACAPAP, that's International Association of Child and Adolescent Psychiatry and Allied Professions, and we're really grateful that you took our time to join in this webinar. We want to thank our presenter, Dr. Marie, for taking out time to share your wealth of knowledge and experience with this community. And we look forward to hearing more from the special interest group that you'll be coordinating under IACAPAP.
Yes, and if all participants would like to be more involved and would also like to answer a few more questions that we still had, then we're very well willing to share those. And if you are willing to fill out those questions, we'll be very happy.
Okay, so on that note, we've come to the end of this webinar. We want to encourage you to look out for the next webinars coming up from our other special interest groups, which we'll be disseminating very soon. Thank you very much. We wish you all a beautiful rest of the day. Thank you,
very
Dr.
much.
Marie. Thank you.
Thank you very much for
Bye-bye. Bye, everyone. Bye.